We are live, please.
Good evening, everyone. Welcome to the number 148th episode of ARC webinar series. So, as you all know, this is the last webinar of this month's cornea series. And today we have long cases and long question and short questions as a part of exam for PGs. So, here we are going to discuss one long answer type and two short answer type, and that will help you in your exam. So, welcome you all to this episode. And today we have three excellent speakers for this webinar. So, the cornea transplantation, which comes as the essay type of question for PGs, that will be taken by none other than Professor Namta Sharma. And Dr. Namta Sharma is a professor at RP Center, AIMS, New Delhi. She is heading the cornea unit, Unit 6, and also the chairperson of Scientific Committee AIOS. Most importantly, she has written a book on cornea transplantation, which is internationally very popular. So I think she's the right person to take on this talk. Next, we have Dr. Sharon D'Souza, and Sharon is working as a consultant at Apollo Hospital, Bangalore. And again, we have taken Sharon for a reason because she is a very excellent trainer in DALK and all the procedures related to cornea. So she is the perfect person to discuss about corneal ectasia. Then we have Sujata Das ma'am from LV Prasad Eye Institute, Bhubaneswar. And ma'am again is an excellent corneal surgeon and also have vast experience in keratitis, dealing patients of keratitis. And she has written a lot of review articles especially on fungal keratitis and other form of corneal diseases. So again, she is the best person to discuss about fungal keratitis. So we'll follow the sequence. First, we'll go for Dr. Namda Sharma's cornea transplantation didactic lecture, then Dr. Sharan, then Dr. Sujata Das. So we have discussed four discussion today. Dr. Vinay Pillai, Dr. Amit Raj, Dr. Shalini Mohan here, and Dr. Sudipta Mitra. So all of them are excellent cornea surgeons, and also they are going to play the role of an examiner here. For students, they will tell you the fine points for all these topics that will help you in scoring a good number in your exam. Dr. Vinay is working as a senior consultant at Girdhar Eye Institute. Dr. Amit Raj is a professor and head of the Department of AIMS Patna. Sir has a lot of experience in taking exams for postgraduates. So his experience is going to help us a lot. Dr. Shalini Mohan is currently the chairperson of Scientific Committee of UP State Ophthalmic Society and also member Scientific Committee of AIS. Dr. Sudipta Mehta, she is an excellent phaco-refractive surgeon and currently the director of RMI Foundation. And again, she has a vast experience in cornea and refractive precision. So her experience will again help us. So I'm thankful to my co-moderator, Dr. Somashala Murthy ma'am, and she has again a vast experience in teaching DNB students and keratitis. So her experience will also help us. And I'm grateful to President Dr. Jeevan Singh Titial sir and Chairperson ARC Dr. Prashant Bhavan Kule for allowing us to conduct this webinar series, and to all the office bearer of ARC as well as my colleague members from ARC. With this, I'll stop my slides and I request Professor Namta Sharma ma'am to share her PPT and to start the lecture on cornea transplantation.
So thank you, Praful. It's a pleasure to be here, to be talking to all the students about a subject which is very close to my heart, and that is corneal transplantation, because my thesis in my MD was corneal transplantation, and I have not left corneal transplantation since the advent of my post-graduation. So I will just share some slides. So I was told that this is for postgraduates, so I've tried to keep it very basic without going into details or going into research details, etc. So talking about corneal transplantation, I think we've come a long way. There are no financial or proprietary interests, and it has been a time-tested technique as far as the corneal surgeons are concerned, and we've known it for last 121 years now. But we are also familiar with the various problems which are there with penetrating keratoplasty. So when you do a penetrating keratoplasty, basically what you're doing is replacing the diseased donor disease recipient, which in this case is keratoconic cornea, and excising the cornea full thickness, and then replacing it with a healthy donor cornea. And then 10-0 monofilament nylon sutures are applied, which can be either done in interrupted manner or can be done by using a continuous suture. So interrupted sutures we generally used for pediatric grafts and for therapeutic grafts. And for cases like dystrophies, degenerations, etc., we like to use continuous sutures. Then we also have what is called as therapeutic penetrating keratoplasty, which is done for ulcers which are not responding to maximal medical therapy to debulk the infection. So you encompass the pathologies, including 0.5 to 1 millimeter of the clear cornea, remove the necrotic tissue, debulk the microbial load, remove all the AC infiltrates and all the membranes, and then wash with the appropriate antibiotics or antifungals. So if it is a bacterial ulcer, we wash with vancomycin. If it is a fungal ulcer, we wash with voriconazole, and subsequently, if membranes are present, then they are removed. And then an oversized graft, which we generally like to do for therapeutic keratoplasty is taken. So normally we oversize it by 0.5 millimeter. The graft host disparity is there. But in case of, for instance, therapeutic grafts or in pediatric keratoplasty, or for that matter in corneoidic scars, we like to oversize by 1.5 millimeter or more than 1 millimeter. For keratoconus, we use either the same size graft or sometimes even undersized grafts. So again, because this is a therapeutic graft, 10-0 monofilament nylon suturing is done, and this is again interrupted. Because there's a chance of recurrence, you don't want that the infection should be there in any of the sutures or infiltrate should be there. And if there is any infiltrate, etc., then we just replace that suture rather than removing the whole suture and replacing it. So like I said, suturing techniques could be interrupted, could be combined interrupted and continuous, could be single continuous suture, and then this could be double continuous suture as well. And there have been studies where you have three kinds of continuous suturing depending on the patterns which are seen here: TOC, anti-TOC, and no TOC. It doesn't matter. There is no change in astigmatism. You can do any kind of suturing. And then, like I said earlier before, that for pediatric grafts, we use interrupted sutures, and also for therapeutic grafts. Because in children, the healing is very fast, so you may have to remove those sutures. And in therapeutic grafts also, there might be infiltrate, so you may have to replace those sutures. Then sometimes the configuration of the graft is different. Like in this case, there was peripheral ulcerative keratitis and perforation. So your graft is not circular, but it is in the form of a crescent. And again, the healthy donor cornea is taken and is sutured onto the host. Then at times you may have to do small circular patch grafts, like in this case, where the membrane over the area which has perforated is removed. Pocket is created all around, and then a graft donor cornea is then sutured, which is about 3 millimeters with 10-0 monofilament interrupted sutures. Then there are problems with the full thickness grafts, which we all know of, like long postoperative visual recovery, ocular surface problems, problems of graft rejection, increased chances of wound rupture after trivial trauma, and change in anatomy of the angle of the anterior chamber, which can also predispose to secondary glaucoma. So for a full thickness graft, we are aware of the suture related problems which can be there, like suture infiltrates, vascularization, high astigmatism, and prolonged visual rehabilitation. And all this has to be taken into consideration when we are dealing with these full thickness grafts. Plus, because of the sutures, there can be suture related problems, graft infection, and even endophthalmitis. And sometimes when the graft is clear, like in this case, then also there can be a problem because of astigmatism. So you may need to adjust the suture. And this is how we adjust. We are using especially the continuous suture. We go from the area of steepening, which we see on the map, and we loosen the suture on the area of steepening and tighten it in the area of flattening. So this is what we get the corneal topography picture in the post-op period. And of course, the most ominous complication of the full thickness penetrating graft keratoplasty is that it is an open sky technique. So you can have expulsive hemorrhage as is seen here. The retinal detachment occurs, the choroidal detachment occurs, the extrusion of the intraocular contents is seen with a full-blown choroidal hemorrhage which is there. So we've moved from an era where we just did the full thickness keratoplasty and partial thickness keratoplasty to component surgery of the cornea, where we do layer by layer replacement of the diseased corneal layer. So we do for anterior corneal opacities, anterior lamellar keratoplasty, which could be manual lamellar keratoplasty or automated lamellar therapeutic keratoplasty. For mid to posterior stromal opacities, we do deep anterior lamellar keratoplasty. And for diseased Descemet's membrane and endothelium, we do either a DSEK, which is Descemet's stripping automated endothelial keratoplasty, or DMEK, which is Descemet's membrane endothelial keratoplasty, or even PDEK, which is pre-Descemet's endothelial keratoplasty. So earlier we used to do our dissection using lamellar dissectors such as this. This is the corneoscleral rim put in the King's clamp, and we are trying to split the cornea. And the only problem was that there would be corrugations like this. And so it will be an irregular kind of a cut which would be there. And that could lead to haze, and that could also lead to irregular astigmatism. So ever since this microkeratome came, it has made our life much easier, simpler, and has opened new avenues into the way we do corneal transplantation. So we do what is called as automated lamellar therapeutic keratoplasty for dystrophies, for ectasias, for degenerations, such as shown here. And basically, the cornea is donor button is taken, which is say 500 microns, split into two, 350 and 150. So the anterior 350 is taken and is then placed onto the recipient bed. This is the recipient bed from which the anterior part of the cornea is split and is removed. And this is replaced by a healthy donor cornea, which is again sutured with 10-0 monofilament nylon sutures and tight suturing because you want to flatten the cone, and this is a case of keratoconus. So you do have interface just like you did in manual lamellar keratoplasty, but this interface is quite clear as can be seen here. These are some of the cases to show ALTK of healed keratitis, Salzmann nodular degeneration, and corneal ectasia. The results are quite good. The visual acuity is generally better than 612 in almost 70 to 95% of the cases, and the astigmatism is less than 4 diopters. And we can do this procedure even by using glue without using sutures, provided the donor cornea is less than 250 microns. So this is a case of spheroidal degeneration with healed keratitis. And this, again, the split cornea is taken and is placed onto the recipient bed. And if it is about 250 microns in thickness and not deeper than that, then one can just use glue. This is the TISSEAL glue which is being used. And notice that you can see how it integrates very well onto the recipient bed, even without the sutures. So this is a case of where we did cataract surgery as well as we did lamellar keratoplasty, ALTK, so that the patient had good vision. And this is the post-op picture of the same. So the opacity which is present here and the cataract which is present here is taken care of by using intraocular lens as well as replacing the opacified cornea with a clear cornea. Coming to deeper part, we have deep anterior lamellar keratoplasty or DALK, where you have maximal removal of the diseased tissue, the Descemet's membrane, which is a smooth graft bed, and there's virtually no interface. And this is done for cases of ectasias, which could be primary ectasia, post-LASIK, post-Intacs ectasias, stromal dystrophies, ocular surface disease, descemetocele. In short, all those cases where your Descemet's membrane and endothelium is healthy. Now, there are various techniques by which you can do DALK, but the gold standard is the big bubble DALK, which was described by Dr. Anwar et al. And I would like you to pay a special attention to this because sometimes you can get this as a short note, that is Dua's layer. So what is Dua's layer? Dua's layer is the sixth layer which is described in the cornea. And this is essentially what is Dua's layer, just above the Descemet's membrane, condensation of the stromal tissue. So if you inject an air bubble above it, you have a type 1 big bubble, and because Dua's layer is there, so it's not very smooth. But if you inject the air bubble behind this Dua's layer, then you have an area which is absolutely smooth because Dua's layer is also removed. This is to show a type 1 big bubble deep anterior lamellar keratoplasty in a case of keratoconus where partial thickness trephonation up to the level of 70% is done, and then followed by the injection of the air in the supra-Descemet's membrane compartment. Now, as the air nick is given in the overlying stromal layers, the air will eject out from the supra-Descemet's membrane compartment, which can be seen here and also can be seen on the intraop OCT microscope, where in a live show, the Descemet's membrane will march towards the stromal layers. Over this Descemet's membrane, the viscoelastic is injected, and now we are dissecting on this Descemet's membrane, which is just 10 microns thin. And notice that we are still extraocular. We have not entered the eye at all because this intact Descemet's membrane is there. And then a donor cornea is taken and 10-0 monofilament sutures are applied after removing the host Descemet's membrane. Just to show a case of Hurler syndrome, bilateral DALC done with a visual acuity of 6.9 and 6.12. And now this is more than 17 years after follow-up. So we are still extraocular and we have not penetrated the eye at all. Some of the, again, cases to show DALC in case of corneal ectasia, trichomatous keratopathy, and macular dystrophy. And this is in case of even chemical injury. And another thing which can be used to dissect apart from the microkeratome is the femtosecond laser. This is the donor cornea in which the femtosecond laser was used, and the anterior part of the layers are then removed with the help of the femtosecond laser. And again, this is more precise as compared to the microkeratome. And this is just to show that in a case of chemical injury, you can still do DALC. This is again a chemical injury with cataract, where DALC with cataract surgery was done with a very good visual acuity in a one-eyed patient. Then when you have peripheral corneal ectasias like this, you have to reinforce not only the center, but also the periphery. We do a different kind of technique there, which is called as tuck-in lamellar keratoplasty, which is done for large cones associated with pellucid marginal degeneration, keratoglobus, post-PK keratoconus, and the advantage is that it is a single-stage surgery with preservation of limbal stem cells, and there's tectonic support to the corneal periphery. Professor Vajpayee, our mentor, both I think mine and Praful's, I can say so, was the one who described this technique of tuck-in lamellar keratoplasty. So when you have cases of keratoglobus, you have a peripheral flange all around and a central full-thickness lamellar graft. But if you have case of pellucid marginal degeneration, then you have a sectoral flange which is present, and then a lamellar graft which is there for the center. So just to show how this technique works, basically what is done is a partial thickness trephonation is done first. And after the partial thickness trephonation is done, the pocket is made all around with the help of the crescent blade. And then the donor cornea is taken. It is trephonated from the back. And the peripheral rim of this is then removed because otherwise it will become too thick in the periphery. This donor cornea is then taken and is placed onto the recipient bed after doing some AC paracentesis because there's too much of bulge, and the flange is tucked inside 360 degrees all around to reinforce the periphery as well. And the sutures are then removed and it looks like a nice graft. You can't even make out that it was done because it is so large and so peripheral. Again, if you have a case of pellucid marginal degeneration, then only the peripheral flange sectorally is present, which is then sutured onto the host with 10-0 monofilament nylon sutures. This was a case in which we did tuck-in lamellar keratoplasty for pellucid marginal degeneration, had a cataract, and subsequently did a cataract surgery for visual rehabilitation. And this was a case of keratoglobus where tuck-in was done 360 degrees. Then for RK ectasias or radial keratotomy ectasias also, we've done tuck-in lamellar keratoplasty 360 degrees all around. And in desmatoseals also, you can do deep anterior lamellar keratoplasty so that you not only tectonically stabilize the cornea, but also give visual rehabilitation at the same time. Now, coming to posterior lamellar keratoplasty, you can have DLAC procedure where stroma and disease membrane, Descemet's membrane is replaced by stroma and Descemet's membrane, such as this. Then you can have DSEC, a procedure where the Descemet's membrane, which is diseased, is replaced by the stroma and the Descemet's membrane, such as this. Or you can have DMAC or PDAC procedure where the Descemet's membrane is replaced by pure Descemet's membrane or replaced by Descemet's membrane and Dua's layer, as in PDAC. So just to show you the first one, that is femto-DLAC, it is technically difficult to do, and so it was given up when it came first. But I still feel that there are some conditions where it is indicated, especially when the anterior cornea is clear and the posterior cornea is the one which is where there is pathology. So this is the donor cornea which was taken, and femtosecond laser was then used to split the cornea. And after doing this, we came to the recipient eye. Here again, by looking at the intraop OCT microscope and by setting the parameters on the femtosecond laser, you remove the posterior part, and the anterior part you will notice is quite clear. So that is left like that only. And this hazy posterior part is removed. Then this had been prepared by the femtosecond laser. So this is cornea is again split, and this posterior part is taken, and the posterior part is then placed inside the anterior chamber, such as this, and then an air bubble is instilled. So this is DLAC. Of course, it is being done by femtosecond laser. So this is the pre and the post-op picture. The corneal edema clears over a period of time, but the hazy part of this is now replaced with a clear posterior Descemet's and stroma. Now coming to DSEC, again, DSEC is a very fine procedure indicated for conditions of bullous keratopathy, Fuchs dystrophy, failed grafts, eye syndrome, wherever endothelium is involved, like congenital hereditary endothelial dystrophy or corneal decompensation post-glaucoma surgery or post-VR surgery. The advantage is that it is a faster visual rehabilitation. So if for penetrating keratoplasty, you have 1 year, for DSEC, it is only 3 months. There are hardly any sutures and the astigmatism is also less. So like I showed you earlier, the cornea is taken and it is split 500 microns. This is a thickness which is measured as 520 microns. So 450 micron head is used. So anterior 450 is used for anterior lamellar keratoplasty. And the posterior part, which is very thin, about 70 microns, is used for posterior lamellar keratoplasty. So what is basically done is that this part is removed and then you can trephinate it. This was a case of Fuchs dystrophy with cataract where epitheliorhexis was done to remove the hypertrophic epithelium. Then desmatocerexis was done to remove the scarred Descemet's membrane. Then anterior capsulorhexis was done to stain it with a trypan blue dye, and then phacoemulsification was done, followed by the 100 microns of the DSEC lenticule, which was intracamerally placed, and then air bubble was instilled. So this is the pre and the post-op picture with the visual acuity of 612. Of course, this is just to show how it is done on an intraop OCT microscope. Not that it is any different, but it helps you to see better and to know whether your graft has got attached or not to the back of the cornea after you place the air inside the chamber. So some of our results, like this was a case of Buphthalmos, one-eyed patient, and we've done a DSEC with very good results on this. And then this was a case of SHED, post-operatively congenital hereditary endothelial dystrophy. So you don't have to do a full thickness graft. There are no sutures and still the cornea has cleared up just by replacing this posterior part of the cornea. When you have grafts less than 100 microns, then it is called as ultra-thin DSEC because the thinner the graft is, the better the quality of vision. So we've used one cornea for multiple recipients. So the limbus for the limbal stem cell transplant, anterior one for ALTK or automated lamellar keratoplasty, the posterior one for the DSEC, and so one cornea used for 3 recipients. And this we published again, the results. So one person who donates can actually rehabilitate 6 patients. Coming to the most physiological graft, that is the DMEC graft. So this is the corneoscleral rim from which the Descemet's membrane is being removed after staining it with the trypan blue dye, and then it is laid back. Further, we triphinate it 8 millimeters in size, and this is now ready for installation inside the anterior chamber. So this is a case of fixed dystrophy from which the Descemet's membrane is removed. And after removing the Descemet's membrane, this Descemet's membrane roll is taken, intracamurally injected inside, and then you get the correct orientation of the biceps curl upwards. When you have it like this, the biceps curl upwards, that means the orientation is correct, and then air bubble will be instilled so that this graft gets stuck to the back of the cornea. And this is post-operatively 1 week, and subsequently this is you can't even make out that the graft was there, as it is most physiological. Now, because I'll talk about PDEC, because that is what many people are also doing, pre-Descemet endothelial keratoplasty. So here the Descemet membrane and the pre-Descemet layer is separated using the air bubble. Just like you do big bubble, a big bubble is made in the donor cornea, not in the recipient. And then subsequently, this is stained with the trypan blue dye, and the graft is then excised with the help of the Vanna's forceps, and this is ready for use now. So again, this is a case of pseudophakic bullous keratopathy, from which hypertrophic endothelium is removed. Then subsequently, the diseased Descemet's membrane is also removed, and the PDEC graft is then placed intracamurally inside. It is easier to handle because it has Dua's layer also. So it is a splitted graft and thicker than the pure Descemet's membrane roll. And this is in the post-operative period. So I think this is the most important slide. Visual rehabilitation after PKP is 12 months, DSEC is 3 months, DMEC is 1 month. PDEC is also 1 month. Now, if you look at endothelial cell loss after PKP is 25 to 28%, almost similar, DSEC is 28 to 30%, DMEC 5% higher, 30 to 35%, and DALC is 2 to 4%. If you talk about phaco, it is about 4 to 8%. Graft rejection, DSEC is 7%, 7 3s are 21. So PKP is 3 times more, 21%. And DMEC, because it is a single membrane, it is only 1%. So this is something which they might ask you in the exams, and this you should know. DALC graft rejection is hardly anything, 0.5%. I think I will not talk too much about biosynthetic cornea, except that we are working on it because there's paucity of good quality donor tissue. It looks very much like your soft contact lens. And this is a case of keratoconus where pocket is being made intrastromally with the help of femtosecond laser. This pocket is open. And this is the biosynthetic cornea which we are working on. This biosynthetic cornea is tryphinated, is folded, and is then placed inside the pocket and is unfolded, followed by a bandage contact lens application. And this is how it looks like, the biosynthetic cornea, which is sandwiched intrastromally. Results are quite good. Keratometry of 89 decreases to 50, and pachymetry of 241 increases to 581. So I think I will not talk about this. This should be the future of biosynthetic cornea, where you would just open the bottle, just like you do for intraocular lenses, and use it ready to implant without having to depend on human donor cornea transplantation. Many people are working on cultured stem cells also, where they can just inject the cells inside the anterior chamber without having to use any grafts. And when you have so many cells, thousands of cells, then one cornea can be used for thousands of patients. So Dr. Kinoshita's group is working on it. These are our books on corneal transplantation, authored by Dr. Ritu Nagpal and Professor Rasik Vajpayee, as well as on DALC and DSEC. So thank you very much for your kind attention.
Thank you so much, ma'am. That was a wonderful and comprehensive lecture. I think students, the important points that ma'am highlighted, the percentages, graft rejection, and also the types, that is what you should know. Because if it comes as a long essay type of question, there are few points that gives you an extra edge over the other student. So if you mark this thing and highlight these things in your answer sheet, and you will score good marks. So I would like to go to Dr. Amit Raj. Sir has been an examiner. So if a long essay type of question comes on cornea transplantation, so what are the important points that student must cover, and that will help them to score good numbers in their exam?
Uh, Thank you, Dr. Prafulla. Excellent presentation by Namrata ma'am. Our madam has almost covered all the things. One of the part that I would like to add is size of graft. Most of the examiner ask what are the side effect of a smaller graft, what are the side effect of larger graft. Why then, if for a smaller graft, there is hyperopic changes, chances of rejection is high. In larger graft, there is chances of pass, glaucoma, even as it is nearer to limbus, so rejection chances is high. Other are related to early complication, late complication of the penetrating keratoplasty, especially different type of rejection, epithelial, stromal, endothelial rejection, late complication like diffuse lamellar keratitis. It is also known as Sand of Sahara syndrome, where in initial grade 1 to just increasing the frequency of a steroid. Later on, one has to basically add systemic steroid also.
So
These
basically,
are the
yeah. So basically, sir, what sir is saying, students, this is a talk that to give you an overview of cornea transplantation, which Dr. Namta has presented. So these are the further details that you'll have to go back and study. And I think if you have time, the cornea transplantation book is an excellent source for that, authored by ma'am only. And yes, we have Dr. Somashila ma'am here. Ma'am, anything you would like to add?
I just wanted to say that Dr. Namrata, it was like a teaching class for us also, not just the PG students.
Mhm,
Not at all.
Especially,
Not for you.
especially on the surgical techniques.
mhm.
You put every surgical technique available for transplants in one place, though of course it was had to be brief. What I have, whatever exams that I have co-attended, I've seen that if you have a cornea specialist as part of examiner, then one question that can be asked is, and can be deliberately asked to confuse the students, would be the type of lamellar keratoplasties. So I think the students should just, it's very simple though, just make themselves familiar with the anterior lamellar keratoplasty and the posterior lamellar keratoplasties. And although Dr. Namita has explained beautifully, but it's and then they may try to confuse you, so don't get confused. So what is, you go from anterior, and then that's for the stroma, and then when you go posterior, it's like endothelial keratoplasty is to replace the endothelium. So we had a student not figuring out the trap that the examiner was leading them to. So be very clear in these concepts, and then you won't go wrong. And also graft rejection was another which you covered beautifully again, Dr. Namrata. That was another question that I think cornea specialists like to ask, even though they're asking PG students, because I think every ophthalmologist should be able to recognize a graft rejection. So that's a reason to ask that question.
Thank you, ma'am. Dr. Sudipta, would you like to add something, or we'll move to the next talk?
I think ma'am has covered it beautifully, and as Dr. Shomshila madam has also added, it's very important to know the basics, which madam has actually covered everything. Ma'am, it's very true what Dr. Mukti said. We've also learned from you. So I think students, you can have a very good overview if you can keep this lecture with you, the points, and very correctly said that sometimes whenever there is a cornea specialist, you always have a question like this about the lamellar part. It's very important for you to remember. So I think we should do the next one. Everything is covered here.
Thank you, ma'am. So I would like to request Dr. Saran D'Souza to share her PPT. So meanwhile, what Dr. Somjula ma'am was saying, often when you're a student, when the question is asked about LK, so we think about DALK only because LK is there in DALK or SALK, but we forget EK part, endothelial keratoplasty. So endothelial keratoplasty is also a type of lamellar keratoplasty that the student must remember. Yes, Saran, please.
One second. For some reason, it is not sharing. Can the team just check? It's not
It was visible earlier, Saran.
okay.
Sunil, are you there?
It's getting muted when I'm sharing.
Sunil, are you there? Sunil, please help.
Can someone from the team just check this?
What happened? You are not able to share?
It's getting muted when I'm sharing.
इसको बुलाओ सुनील Zoom. I have his number. I'll call him. I'll call him.
Sorry for the delay. If you want to take the next talk, Praful, it's fine to save time till they figure out what's.
Okay, Sujata ma'am, if your PPT is ready, you can start your talk.
Sharon का देखो जरा.
I'll try to.
How can I help, Dr. Sharon?
Actually, when I'm sharing the screen, it's becoming mute. My thing is automatically getting muted and I can't unmute it.
Can you just share again? I'll try to unmute you from this side.
Yeah.
You joined from application, right?
No.
Browser.
Browser.
Sunil,
You need to
call
log off and log in, doctor. Browser you can't share.
Sunil, you
Okay.
call Dr. Saran and sort it out.
Yeah, you all
Meanwhile,
please
Dr.
go ahead with the
Sujata
next
will.
talk. Yes, please.
Yeah.
Thank you.
Okay, I'll share.
Yes, ma'am.
Can you see?
Yes, ma'am. We can see your slides.
Okay. Okay. Thank you, Praful, for inviting me in for this ARC webinar. So I'll be speaking in another common condition, which is fungal keratitis. Again, it may come as a diagnosis and management separately or combined. Okay, so that's it accounts for 30 to 50% all microbial keratitis in developing countries. So if you see the statistics here, this is culture positive, and in India, it is like the percentage of fungi you can see from 8.4 to 71.9. So India is in between. India has almost around 50% of microbial keratitis is due to fungi. So if you come to see the what is mold, so yeast is very less here. So yeast is almost 0 or less than 1%, whereas in India, the molds is almost 95 or 98%. If you see in this paper, it is 100% is mold. Again, the percentage of Aspergillus and Fusarium varies across different countries and different place. In North, we have a lot of Aspergillus, whereas in south it is fusarium. In I think in center east we see almost 50%. So in the world you can see Candida is in the North America and Fusarium aspergillus you can see in India, both are there. So what history when the patients come, what history we should ask? Ocular symptom, because from bacteria it is usually acute, few days, whereas fungus it's sometime it may be few days to few weeks. With the contact lens use, we don't see contact lens use mostly in our history, but somehow we have to take this. And the fungal keratitis mostly trauma with vegetable matter. So prior ocular surgery, it may be corneal surgery, it may be cataract surgery, because immediately after cataract surgery, fungal keratitis has been reported. Any medication patients are taking, especially if it is immunosuppressive and ocular steroid. So you need to take the history of diabetes. In case they're not known diabetic, any microbial keratitis come, it is a routine practice. This should rule out diabetes. And some fungi are normal part, even normal normal person, you get aspergillus, candida sometimes. However, unless there is any predisposing factor, they are not pathogenic. So there has to be some breaks in epithelium to have infection. So these are the predisposing factor which you take as a history or as a part of examination. So ocular, and it is divided into ocular and systemic. All ocular, like dry eye, starts from lead. When we see a patient, rather than jumping to slit lamp examination, we should start from the history, then the eyelid examination, because in eyelid you can see entropion, ectropion. Sometimes you may miss directly slit lamp examination. So all these like lagophthalmos, neurotropic keratitis, all these are for microbial keratitis. It is not only for fungal keratitis. Like for example, dacryocystitis. Most of the time we see bacterial keratitis due to dacryocystitis. So this is also a part of the protocol that you have to rule out dacryocystitis in cases of microbial keratitis. So prior medication, this will not only help you in the diagnosis, also like for example, somebody is on antifungal and it is responding to antifungal medication. So you may not get organism if it is a resolving keratitis. From the history, you will know whether that was improving or worsening. This history and what medication patient on. Unfortunately, many times we see cocktail therapy, but you can always ask if it is how frequently, because maybe medication was correct, but the frequency was not correct. So commonest risk factor what we see here is trauma, but corneal surgery also sometimes like cataract surgery. So trauma we analyze in 10 years history and of trauma was in 13.9%. And those who work in outdoor are more likely to have trauma than compared to indoor. And contact lens, like if somebody has a contact lens, using contact lens, type of contact lens, and the hygiene is most important. So we ask them to get the contact lens and solution when they come next time. So this picture you can see in between, I think around 2006, a lot of contact lens induced fungal keratitis, and this was mostly due to a solution. You can see this fungus is inside the contact lens. It is in the contact lens matrix. So always the patient are contact lens user, please ask them to get the contact lens and solution. Again, in contact lens, the patient use cosmetic contact lens is mostly for filamentous, and if you are using therapeutic contact lens, bandage contact lens, most likely Candida. The outbreak I was telling is it was due to fusarium and associated with contact lens disinfectant solution. So this is a patient with a contact lens user who has a microbial keratitis. And all of us know steroid is no absolute contraindication in fungal keratitis, because it not only activates, it increases the virulence of fungi. Because it decreases the local immunity. So because this is a main risk factor in the graft. If somebody has a graft and using steroid, because normally we need steroid sometime for lifelong. So this topical steroid use may be a risk factor in cases of graft. So corneal surgery, it may be graft or it may be laser refractive surgery. Again, in laser refractive surgery, we may see within few days, immediate acute onset or delayed onset. So this you can see there is a flap, and this whole flap is melted. So all type of fungal keratitis has been reported from laser refractive surgery. This is cataract surgery. You can see the cataract wound. So it has come from the tunnel, and whole cornea is almost half of the cornea is infected. Systemic risk factor, like I told, diabetes mellitus is a routine, and patient who has used systemic corticosteroid is a predisposing risk factor for fungal keratitis. And another systemic cause, candida, we don't see often, but candida, those who are in ICU are predisposed to candida. So if you see ocular trauma, in ocular trauma, fungus, bacteria, both are there, but in ocular trauma, mostly it is fungus in all the reported studies. Similarly, contact lens wear, fungus is very unlikely. If you see out of 133, 3, here it is almost 0 because we don't see contact lens user keratitis. But bacteria, it is the common cause for bacterial keratitis. Similarly, ocular surface disease, bacteria is most common, and most commonly we see staphylococcus and streptococcus. But there is not unusual to have fungal keratitis because again, the steroid is one of the risk factor in addition to ocular surface issue. So how do you differentiate between fungus and, because one of the criteria is it is slow growing. But some bacteria also are slow growing, like Staph epidermidis. Pseudomonas may be acute, but some other organism which are slow or growing, we should rule out when we take the history. So we have to remember what are the typical clinical features. So this, if you see this is almost, I'll say, like 90-95% it is fungus. Again, the hypate age. But again, the hypate age has started confusion with reticulate age of pythium. So we need to rule out in laboratory diagnosis, but these are some typical features. So satellite lesion, but again, satellite lesion has been reported from other infection also. So this is, I'll say 100%, like others I was saying 95%. This, if you see, there's no doubt, this is a dematitis fungal keratitis. Many times if you scrape, this comes out in toto and it helps in early resolution. So thick hypopyon, another cause which is a horizontal margin. Thick hypopyon is endothelial exudate. Thick hypopyon is another typical feature. But you may not see typical features always. So these are all raised plaque-like lesion. In those cases, especially the debridement, although debridement has shown it does not affect the final visual outcome, but this raised lesion, we should do debridement while doing corneal scraping. So whatever classical clinical feature, they are not exclusive or distinct by a slit lamp picture to distinguish from other organisms because we have some atypical feature. If you see this is look like tendrite. This is very, very early fungal keratitis. But you need to rule out by doing scraping. The first examination, you will always think this may be. There are other ways where you can know whether it's a viral keratitis. You stain with rose bengal and fluorescent. So this is typical. This is not very unusual, but only thing is it is very deep. There's no excess. There's no epithelial defect where you can see. And if you put this slit, this is quite deep. So most of the time, either if you have a confocal, then you can do confocal, or people do endoscraping or Ishita for PCR. This looks like bacterial keratitis. This looks wet and melting. This looks like a viral keratitis which is melting, but all this also can be atypical features of fungal keratitis. This again, after cataract surgery, most of the cataract surgery wound, you feel it is a bacterial, but fungus can be equally responsive. This is very confusing. This looks like fungal keratitis, but if you see the edge with a higher magnification, this is reticulate edge with wreath-like appearance, which is typical of nocardia keratitis. And usually they give history of trauma with soil. So this paper says that whatever is the clinical feature, it is not completely 100% pathognomonic of any organism. So we need to rule out by microbiology. So these are the common tests used to diagnose. So gram stain and KOH is the mandatory, even if like it is for postgraduate, I know, but in case you have, like in case you are not doing in medical college, you can do to rule out if, unless you have access to culture media, but this is the simple test which you can rule out. And it is a very good high sensitivity and specificity. And so fungus grows in all these media. It is SDA is required for identification of the species, but it can grow equally. In fact, it grows faster in blood agar and chocolate agar. If you have a small also like 1.5 into 1.5, then you can take one of this rather than taking whole battery of test. So put paraffin. If the slides are sterile, you can use 15 number blade. Unless it's a child, we don't have to put a speculum. You can do in slit lamp examination. Take 2 slides and put C. Don't go into the culture media. Don't do too deep. So fungus grows, and there are criteria to diagnose any bacteria or fungus which is significant or not once it grows. So it should grow in the C, not beyond this, and it should have a smear positive. This how fungus looks. And nowadays, again, another common differential is Pythium. But Pythium will have less septa and it will be ribbon-like fold. So you can use either KOH, because unless it's calcopro white, you can use simple KOH also to do this. And smear positivity, if you can see KOH is KOH with calcopro white is 91%. Gram also is not bad, it is 88%. So this is published. How is the sensitivity and specificity? You can see this is for fungi, it is 90% sensitive and 94% specific. And you can see the culture. It takes usually 24 to 48 hours, but in general, depending on the lab, it can be kept for 7 days, or sometimes we generally keep for 2 weeks, but depending on the load. So Fusarium aspergillus, sometimes if the load is too high, they grow in 48 hours. Nowadays, antifungal susceptibility is also done in some labs, but it is not routinely done because we have limited antifungal available. This is quite expensive. It takes a lot of time also. So from this, if you know the species from the color, and then lactophenol cotton blue helps to identify. Like I mentioned, blood agar it is 56% compared to SDA. So blood agar is also equally good unless you want to do subculture and identify the species. If you have access, another thing is confocal. Especially it is useful for deep fungal keratitis where there is no material to scrape. Or you can do biopsy also. If you don't have confocal is quite expensive and it is not very user friendly. Corneal biopsy also another route where you can, if it is deep stromal, you can do this. So how do you diagnose in confocal? It is hyperreflective double-walled septate filament. It is usually long. Sometimes it gets confused with corneal knobs. So length is uniform width and irregular branching. Again, how do you differentiate Fusarium and Solani and Aspergillus? This again is not very pathognomonic, but it is described. Fusarium branches at 90 degree, Aspergillus at 45 degree. So this is a patient which I showed earlier. I think this is the only confocal can help, or ACTAP sometime, because fungus is just sitting next to the desmet. Biopsy is just absolutely, you can't do it, it will perforate. Either confocal where you can see fungus, or if it is not responding, then you go for therapeutic keratoplasty. So sensitivity, specificity is around 90% in confocal. So the documentation is most important. Now most of the colleges and private practitioner, everybody has a slit lamp camera. But as a PG student, it's always a good idea to measure the length and breadth so that you can know whether it is responding to medical treatment or not. It helps you in decision making. And B-scan again is mandatory to do rule out endophthalmitis. In case you can see fundus, it is fine, or else B-scan at first visit, or in case it is worsening, you can do a repeat B-scan. So coming to treatment, the aim of treatment in any microbial keratitis is reduction of number of pathogens by medical management and control of inflammation and tissue damage. The second part is really challenging in cases of fungal keratitis because we can't give steroid. And we don't have many antifungal available, and most of them are fungistatic. And no treatment, like I mentioned, no treatment for inflammation or tissue damage. And most of the patient are present. So these are the challenges for fungal keratitis management. Is a narrow spectrum, the penetration is bad, and frequent use may lead to toxicity. So in vitro antifungal susceptibility, like I told, some labs have started doing, but sometimes it may not help you in, because in case, for example, fungal keratitis, the fungus takes 4 to 5 days to grow, then susceptibility takes few more days. So by the time you have started the medication, you know whether it is responding or worsening. If it is worsening, sometimes they need medical management. Even if the labs are started doing, there is a poor correlation with clinical response. And we have only few medication. Even if we do, theoretically, it may not help you. So common medication used is, first line of management is natamycin. So this may be the question, what is the classification of antifungal? Polynol, azole, and flucytosine. And systemic is most commonly used is ketoconazole. And newer voriconazole is not very new. It is there in the market for last 8 to 10 years. Even one company has come without formulated. Otherwise, you have to make your voriconazole solution. Posaconazole is being used, and some RCT is ongoing. But again, it is not readily available in the market. Echinocandins are few publications in case report and case series about echinocandin use. So voriconazole in vitro has very good result, but in vivo it has not shown advantage over natamycin. But in vitro, it is broadest spectrum of antifungal level and therapeutic aqueous level after oral administration, as it's it. So this is again I'll say for post-graduation should have read MUT1 and MUT2. MUT1 is mycotic ulcer treatment trial, where the efficacy of voriconazole was compared with natamycin. The conclusion was is not any added advantage. And the final outcome, there is no difference in scar size, perforation between two groups. Echinocandin, in comparison to others, is water soluble. It works by inhibiting beta D glucan synthetase. It is excellent activity in Candida aspergillus and low toxicity. So these are the few case report and case series where echinocandin has been used. In addition to topical administration, we can use intracorneal and intracameral. But all these are in addition to topical medication. Only this will not work. And intracorneal, both voriconazole and amphotericin B can be used. But there are some studies again say the intrastromal did not offer any advantage of topical therapy. But my personal experience, if it is quite deep and recalcitrant, we can always add topical to intrastromal. Intracameral, again, both voriconazole and amphotericin can be used. Currently, it is mostly voriconazole. Amphotericin cause a lot of iris neovascularization. Limitation is we need to give frequent injection. So how do we know whether it is going to respond to medication or not? Usually the risk outcome for poor outcome is large ulcer size at the presentation, presence of hypopyon, and infection with the aspergillus. Usually 30 to 40% treatment failure that requires some type of surgery for restoration. These are some of the medication, MIC 50, MIC 90. You can see for aspergillus, posaconazole has lowest, and for fusarium, voriconazole has the lowest MIC. Again, another one for amphotericin has lowest for fusarium and terbinafine, which practically we don't have terbinafine. So we need ideal molecule which will have wide spectrum of activity. It should be water soluble, better penetration, and low toxicity. So coming to surgical treatment, when medical treatment fails, we need surgical. So main indications are refractory to medical therapy, or the progressive thinning, which might need tissue adhesive, bandage, contact lens. Perforation, smaller perforation can be managed by glue, and large perforation keratoplasty. Like Dr. Namrata has told, we need interrupted suture in perforation. And advanced keratitis, we can go from the first day. And on diagnosed, like I showed one case which we don't know. So various surgeries, superficial keratectomy, sometimes it is a plaque, and mostly in dermatitis, you can remove the plaque. It helps to resolution, decreases the organism load. Tissue adhesive for thinning or small perforation. Patch graft, if it is a perforation which is not amenable to tissue adhesive and it is in periphery. If it is a central one, better to do a large keratoplasty. And conjunctival flap, if we don't have tissue at our hand and we need a tectonic purpose, it can be done. So this is a patient with a keratectomy. You can see the dermatitis fungus, whole plaque has come out. And the organism load was mostly on the plaque. So this is one small perforation which is managed by tissue adhesive. And keratoplasty, there's no question of lamellar, at least in our setting, because most of them comes with a full thickness infiltrate. Even if it is not full thickness, we don't know the load. So the goal is excision of infected tissue to decrease the microbial load and preservation of structure. Secondary objective is restoration of vision. So although theoretically lamellar keratoplasty, but I'll say that we should not try lamellar keratoplasty in fungal keratitis. It may be for bacterial or acanthamoeba. Penetrating keratoplasty in comparison to lamellar is simple, less time consuming, and complete excision of disease cornea. So the risk graft rejection, intraocular complication, we know glaucoma and PAS, all those in large graft. Lamellar keratoplasty in comparison to penetrating, no intraocular complication, we can use any quality of cornea, but you don't know because most of the time the fungus has gone beyond this. So we don't know while dissecting, we don't know whether they completely cleared or not. So this paper says recurrence in almost 7.3, but those are early cases of microbial keratitis. So you can see the most of the even 31% has in anterior chamber. This is the study of corneal button, diffuse in 50%. So posterior 1/3 also there's hardly anything which is only anterior. The risk factor for recurrence is mostly infection by aspergillus and preoperative use of corticosteroid if there is a hypopyon endothelial exudate. So basically the protocol for diagnosis is you do smear and start antifungal medication. If responding to treatment, continue. If spear negative, you either do repeat corneal scraping, you can give a drug holiday if patients are using antifungal. We have access to confocal and culture. And if it is worsening, either substitute or add medication. And if still worsening, surgical graft. And most of you maybe knowing TST protocol, which is started by RP Center. So same like if you size of ulcer is more than 5, you start with one medication, topical natamycin. And if it's a good response, then you continue that. But poor response, you add voriconazole. If still poor response, like you can continue both or intrastomal, intracameral, both antifungal injection, or not responding, therapeutic keratoplasty. So to conclude, we need to do microbiological workup for diagnosis of any microbial keratitis. And current treatment methods frequently fail to restore vision. So there is a need for an ideal antifungal agent, and we need to take decision when we plan to do surgery, and close monitoring is important.
Thank you so much, ma'am. And I think this is probably covers the entire part of fungal keratitis. It may come as long question or short answer type. And I request Sharon to share her PPT. And meanwhile, I'll go to Professor Namta Sharma, who has a vast experience of managing such fungal keratitis. And the last TST protocol was by ma'am only. So, ma'am, would you like to add anything? And Sharon, please start sharing your PPT.
Now Praful will add when he modifies this TST protocol, he has an idea. So he will modify it and then further elaborate it. I think Sharon's presentation is started.
Yes, Sharon, please start.
Sorry for the issue earlier. So today, thank you very much, Praful and AIOS ARC, Namrata Madam, Sujata Madam, Dr. Somshila, and Dr. Amit, and the entire team for this invitation. So corneal ectasia for postgraduates basically can, as Praful was saying, come as a short question. There are multiple points that examiners tend to ask about it. So I'll try to keep it short and highlight the main things. You can also get it during your Viva, or some topo may be shown. So something like that. So what is ectasia? So the confusion starts from that, and many people confuse thinking that the entire, the thinning, protrusion, everything is the ectasia, but actually it is only the protrusion of a structure which is an ectasia. But when we are talking about corneal ectasia, it is a condition in which there is a thinning and protrusion of the cornea. Now, there are different kinds of ectasia, and the difference lies in where the thinning end is and where the protrusion is, and we'll come to that. So the hallmarks, and I've put small question marks where small cues, wherever, it's a possible question, but pretty much everything, I've just highlighted the main things which may come as questions. So the hallmarks of a corneal ectasia is a condition where there is corneal steepening, there is thinning of the cornea. This results in irregular astigmatism, which in turn, because it's irregular astigmatism, results in a reduction in the best corrected visual acuity. And associated with this thinning, of course, is a biomechanical failure. So the types of corneal ectasia, primarily the most common being keratoconus, then you can have pellucid marginal degeneration, keratoglobus, posterior keratoconus, and sometimes a secondary cause like post-refractive surgery, be it LASIK, RK, post-trauma due to scar, or some connective tissue disorders. But we'll be concentrating mainly on the primary causes of corneal ectasia. So the three most common ones are keratoconus, pellucid marginal degeneration, and keratoglobus. So you see that even though they are come under the entire big blanket of ectasia, they look very different, they present very different, and we'll be going into what is the difference between these. So as you see in the image of keratoconus, there is either central or paracentral, could be inferior thinning, but the area of protrusion does coincide with the area of thinning. And that is the key difference from pellucid marginal degeneration, in which the thinning is much more peripheral and inferior, and the ectasia or the bulging is above the area of thinning. The third one being keratoglobus, in which it is a diffuse thinning all over, limbus to limbus almost, and an entire protrusion of the cornea. So you see they are very different in their presentation, and we'll go into more details. So keratoconus is definitely the most common one we see. It is a progressive corneal steepening. Over time, it may slow down or stop progression. It is typically central or inferior. Incidence varies, depends on reports, but it can be from 50 to 230 per 100,000. It's most of the time a bilateral condition, but asymmetric in presentation. Unilateral involvement, as you can see, is very, very low. Onset is usually around the age of puberty, so it's early teenage to early adulthood. Even though the hereditary or genetic form of it gets highlighted a lot, it is important to remember that actually that's a very uncommon cause of keratoconus, with a frequency of only around 6%. More likely, it can be just a random presentation. And keratoconus prevalence once you have a first degree relative is only about 3%. Now, what is the common pathogenesis? The most common pathogenesis. So remember that earlier keratoconus was thought to be a non-inflammatory pathology because of its quiet appearance clinically. But now, over the last many years, it has been found that it has an underlying inflammatory pathology. So there's a lot of role of the molecular markers and cytokines. This results in collagen fibrillar disorganization, which has weaker bonds between the collagen fibers and results in reduced biomechanical strength and loss of stromal volume due to the degradation of the extracellular matrix due to the release of various proteinases and matrix metalloproteinases. So this is a very important slide because the history and examination is something you can get a number of questions on. History-wise, frequent change of glasses, vision not improving to 6/6, history of ghosting or shadowing of images is a very important history. On examination, any high cylindrical refractions, a skewed or odd axis. What we mean by that is that if it's not our usual 90, 180, more than 20 or 30 degrees off, that is a red flag. Retinoscopy is extremely important because you get something called a scissoring reflex. Now, what is a scissoring reflex? Basically, in myopia, you remember in your retinoscopy, it's a against reflex. With hypermetropia, it's a with reflex. In keratoconus, because of the irregularity of the cornea, the reflex from your retinoscopy actually gets split and moves like a scissoring appearance, and that's called a scissoring reflex. In this slide, I have highlighted some other signs which are named signs and are often asked. And you would need to know not only the name, but also what is the position of it and why it forms. For example, Fleischer ring is an iron deposition along the basement membrane of the epithelium. It forms around the base of the cone. Vox striae are these vertical, very fine striae in the cornea. So remember, in a viva, it can be, once you have some iron deposition, they may ask you what are the other causes of iron deposition. So there are a number of other lines and depositions, Hudson-Starley line, Stocker's line, things like that. So the questions can go along those lines. Vox striae, once you can get other kinds of striae which you see, Harp striae and others, which you see in which conditions. Now, what is Munson's sign? In a very advanced keratoconus, when the person looks down, there's an indentation of the eyelid, and that's Munson's sign. You get oil droplet line sign or the Charlot sign because of the reflex on retinoscopy. And a Rizzuti sign where if you put the light reflex from one side of the limbus, because of the irregularity of the cornea, you get a very high illumination at the other end of the limbus. So these signs are important and you need to remember. Now, of course, the most important risk factor is eye rubbing and allergy, without doubt. The most important risk factor for developing a keratoconus, but you can have certain syndromic associations like Down syndrome, Ehlers-Danlos syndrome, Marfan syndrome. So you need to know the names of what are the possible associations along with it. The diagnosis of any of the ectasias is primarily based on some form of topography. It started with what we knew as a Placido disc-based topography, but has evolved over time. And now the most common one is the Scheinflug-based topography or tomography. These are the various topographic patterns of the cornea. But what I would like to highlight is that not all of them are abnormal or could be abnormal. But whenever there is a skewing, which is the deviation from the 90-180, or there is an asymmetric superior-inferior asymmetry, those become red flags for us to diagnose a keratoconus. As I was saying, the most common or most useful kind of imaging is the Scheinflug imaging. You need to know what a Scheinflug imaging is, just in very brief, not too much detail. But what you remember is that from that you get a topographic map like this. So I'll just very quickly highlight briefly what we are looking for. So as I was saying, inferior irregular steepening on the map, anterior and posterior elevations. This is an elevation-based topography, so any increase in those. And the thinning, the steepening, and the elevations should coincide, and that would make the diagnosis of keratoconus. We also have something called the Bellin-Ambrosio ectasia display, which helps us further to pick up very early cases of ectasia. There are two very important classifications of grading, one being the Amsler-Krumisch keratoconus classification, which grades it based on the K values, that's the keratometric values, the scarring, and the apical or central corneal, the thinnest cornea thickness, which is available to us. And the other one, which is more recent, is the ABCD classification for keratoconus. Both of these you can read up and learn, but at least you should know the names roughly. You don't need to know it in too much detail. In addition to the thinning and steepening, as I was saying, there's also a corneal biomechanics or biomechanical weakness. That is basically the strength of the cornea goes down. And the two main devices used to check that are the ocular response analyzer and the Corvus. At least you should know the names of this. That should be enough at the postgraduate level. Coming to the management of keratoconus, roughly, we remember that keratoconus can be stable or progressive. If it is stable, our main goal is to try and improve the vision, which in early stages can be glasses or contact lenses. And if the patient does not want to wear either, and there are certain criteria for looking at it, we can try phakic IOLs. However, if it is a progressive keratoconus, then our first aim is to try and stop the progression. This is by a procedure called collagen cross-linking. Once it is stable, then you can go ahead with the visual rehabilitation. In advanced keratoconus, where glasses will definitely not help. We can use specialty contact lenses or may require some form of a corneal transplant. So just very briefly about corneal collagen cross-linking. Basically, it's the only procedure known to stop a keratoconus if it is progressing. The corneal tissue is strengthened using riboflavin, which is vitamin B1, as a photosensitizer, and UVA light. And this increases the covalent bonds between the collagen, which are weak initially. It improves that cross-linking to improve it. One name that you must remember is the Dresden Protocol, which was the original protocol. You don't need to know too much more in detail. Nowadays, we use what are called accelerated protocols. When we go to advanced keratoconus, as I was saying, we either have options of transplants, as Dr. Namrata so beautifully showed. Because keratoconus is a problem of the anterior part of the cornea, the anterior pathology, so we usually prefer to do an anterior lamellar keratoplasty. But if in very advanced cases, you may also need to do an optical penetrating keratoplasty. So our options for advanced ectasia are deep anterior lamellar keratoplasty or an optical penetrating keratoplasty, where we have to do a full thickness cornea, and both of these do very well. Of course, Madam has already described the advantages of both. Specialty lenses in irregular corneas have been a boon. You should at least know the names of the most common lenses. The scleral lenses are a very common option now, and the Rosquet lenses. I don't think you need to know in too much detail about them, except that they are used in very irregular corneas and they are much larger diameter. Fitting is very different. They are a hard lens, which usually needs a plunger to be inserted and removed. The other ectasias, very quickly, next most common one is pellucid marginal degeneration. It is again a bilateral corneal ectatic disorder. Unlike keratoconus, in which the thinning and the ectasia, the protrusion, coincided, here the thinning is much more inferior. The protrusion is above the area of thinning. So this, in more advanced cases, gives what we call the beer belly appearance. Another difference from keratoconus is in keratoconus, you get a with the rule astigmatism. In pellucid, because of the inferior thinning and protrusion, you get an against the rule astigmatism. Another very important name which you need to remember, on topography, you get a crab claw or a kissing dove pattern, as is shown in this image. It also has a much later onset than keratoconus and can progress later, so well into the 5th decade also. Management does not change much. Early cases, you can try a cross-linking. More advanced cases, you need to modify your techniques for transplant. So either a very large graft or a decentered graft to try and include the entire area of the thinning and the ectasia. Keratoglobus is probably one of the most difficult to handle because it's extremely thin, it's diffusely thin and marked ectasia. Very often they may have a syndromic association, and it's also known as a brittle cornea syndrome. So the patient may present itself with a perforation which may be following a very minor trauma. So you have to be very careful in handling these cases. No excessive or over-enthusiastic surgery. Usually we prefer a conservative approach unless there is a reason to operate them. And the last being posterior keratoconus, which is much rarer. It's a congenital abnormality in which it comes more under mesenchymal dysgenesis, and there's an indentation of the posterior, the DM endothelium into the stroma, which results in a little bit of scarring. So in summary, these are the main, this is a chart which shows all of the 4 conditions. The most common being keratoconus, least common posterior keratoconus, and the differences in the thinning and the protrusion, whether there's a deposition of the Fleischer's ring, whether there's scarring, what are the kinds of signs that we see mostly in keratoconus. So this would help you differentiate between all of those. So with that, thank you for a very patient listening.
Thank you so much, Sharon. I think that was a quick review of corneal ectasia, and mostly students get a short case or short question. At times it may come as a long question also, but you have covered all the aspects. So I would like to request Dr. Namrata, Dr. Somshila, or Dr. Sujata ma'am, if they want to add anything to this, or else we'll conclude the session.
I think there's nothing to add. Sharon has covered everything. Somshila, do you want to add something?
So for
Yeah.
students, it's important. They may ask you to demonstrate this rigidity and Munson sign if you get this keratoconus as a long case. So you people should remember exactly what is written in the textbook and do it like that. Because if you don't do that, then that's a negative score to your total.
Also,
So other than that,
retinoscopy,
yeah.
sometimes they may actually ask you to, even if it's you don't see it, but at least demonstrate how you would do it. So,
Yes, that is also they may be asked.
For
I
the
think ocular and systemic association with keratoconus also can be a question for PG students. Like
Yes.
VKC and OBKC is a common condition.
for the students, I think that it's the best chance for you to take the examiner into areas that you know. So if the examiner asks you about what are the signs of keratoconus, you can impress them by saying that there are these 7 signs of keratoconus. Please count them and go. But as far as I remember, Sujata, you might remember Dr. Rao used to always answer 7
Yes.
signs of keratoconus, and make sure you mention that, starting with oil, all the reflexes, and then the rings. So you can push them into talking about rings on the cornea, and you make sure you
Yes.
know about the rings on the cornea. So I'm sorry if any examiners are listening here, but this is one hack for PG students. Similarly, even Sujata took an excellent lecture on fungal keratitis. There also, every time it was striking me that there are ways in which you can lead the examiner into asking you questions what you know. The examiners want you to pass. They want to ask you questions which you can answer. Nobody likes to have a student not replying. So it's good to don't just show your things that you don't know. Don't go there and try to talk about things that you do know. Excellent talks, Sharon, and excellent talks, Sujata.
Thank you.
I think with this, we'll conclude here. Thank you to all the speakers and all the discussions for today. And our webinar extended little bit, but I think students won't mind that because these are the 3 very important topics, and at least 1 or 2 questions must be there from this 3 topics in your exam. So I think I hope this will help you all. And with this, I would like to thank you, AIRC, and our chairperson, Dr. Prashant Bhavankule, sir. And we'll conclude here. Thank you and good night all.
Praful, before you
Good night.
leave, I want to
Yes,
thank
Somchala
Praful.
ma'am.
I want to thank Praful for putting together this entire month for ARC on cornea. Praful, you've gone through a wide variety of topics, starting with journal club discussion, case presentation, directed lectures. And I think today was the icing on the cake. We had wonderful lectures by such renowned experts. And this entire 1 month's content is excellent for the PG students. Certainly, I would ask them to go back again and again and to review the content because there was so much in it for them for this month. Thank you, Praful.
Thank you, ma'am.
Good night.
good night.
Congratulations.
Thank you.
Thank
Good
you.
night.